actually contributed to the circumstances in which she died. But then another idea. So when Michael was presenting at the beginning, he had a slide, a word cloud slide with complexity in the middle and lots of things around it. I've chosen a different icon, which is a Gordian knot, the way that a knot can be so exquisitely pulled together that it feels insurmountable to untangle it. The complexity is too much. And there were some moments, I think, in what happened in relation to Amanda that were a bit like that. It was really hard for people to see a clear line about how to keep her safe, given that those working with her were accustomed to a level of trouble. And I'll talk a bit about that. Next slide, please. So just a bit about Amanda. And Amanda's her name. And with great love and generosity, her family contributed to the Safeguarding Adult Review, and they also enabled us to use her name. We offered them a range of options, but Amanda was her name. So she was white, and she was born and grew up in the Lewisham locality, around and about, not always exactly in Lewisham, but round and about. And she was a very talented artist. She came from an artistic family. And her identity as a family member was strong. She was the mother of 2 children. They're now young adults, but sadly, because of the circumstances of her life, she wasn't able to bring them up. But they were brought up by her sister, and she maintained contact with them throughout her life and throughout their life. Quite early on, she was diagnosed with paranoid schizophrenia. But at the time that she died, she had very few schizophrenia symptoms. There were other troubles that she was experiencing. So there's some question from her family about whether that was a full and comprehensive enough diagnosis. But nevertheless, schizophrenia was sadly part of her early experience as a young woman. Next slide, please. But alongside her mental distress, she used substances, again from a very young teenage age. Depended what was available, what was fashionable, who she was mixing with. But in the times before her death, alcohol was her substance of choice, and she was wholly dependent on alcohol. She had a range of physical health problems, some of which had come about because of her very extensive alcohol use. She was living in a care home in Lewisham, and because she had been detained under the Mental Health Act in some time back, her care in the care home was funded under Section 117 of the Mental Health Act. She was, in fact, making really significant efforts to reduce her alcohol intake, and was proven to be doing that. So that was coming up on some of the tests that she had to do. She was doing tests partly because she was on the road to a residential placement for an alcohol detox. There had been times in her life when she had been detoxed, and she was on that journey again. Amanda was very well known to services, both NHS services, the care home where she lived, and third sector services, including alcohol and substance misuse support. So when I looked at the chronology, there were over 1,300 lines in the chronology for an 18-month period. Now, that doesn't mean 1,300 contacts, because sometimes people were talking to each other, sharing information, but it shows the intensity of the involvement around Amanda. Next slide, please. Now, something which was a bit opaque in terms of people's understanding was that Amanda socialized quite a lot with people who live and carry out their social life on the street. So people who sleep rough, people in drinking schools. So that was a fact that became more important as we understood what had potentially happened. She went missing from her home, where she lived, the care home, in May 2019, and her body was found just under 2 months later in a boarded up garage. So a garage that had been derelict, and her body had been hidden there. So it wasn't that Amanda had been there and unfortunately found herself locked in. Her body had been hidden there. Now, the police investigation into the circumstances of her death has been completed, so that has been done, and a file has been submitted to the Crown Prosecution Service. But the action that is going to happen next is not in the public domain, and we don't yet know when the coroner's inquest will be resumed. So the cause of her death is not yet determined. Next slide, please. So when the SAR was commissioned, these were the kind of broad themes. There was some detail, but these were the broad themes that I was asked to have a look at. How the relevant law and guidance was applied in Amanda's care and support, her physical health needs, whether the safeguarding processes have been followed correctly and adequately from the agencies that were working with her, how her risks had been assessed and managed, and how the agencies that were working with her had supported the workers who were working with her. And we also had some questions about community safety issues, given the population that she was mixing with and her vulnerability. Next slide, please. Now, one of the frameworks that I used in thinking about the work that had happened with Amanda is from a publication that Michael Preston Shute is a co-author on, and it's a highly recommended publication if you're working with people who have alcohol or substance misuse issues. And it's titled How to Use Legal Powers to Safeguard Highly Vulnerable Dependent Drinkers in England and Wales. And it's a stepped process. I'm not going to go through all the detail here, but basically you plan your interventions with the individual concerned in a stepped way, and if the least intrusive options don't work, then you start to move along the staircase of interventions. So I'm going to talk a bit about that, but really recommend that as a resource. Next slide, please. So in setting the context, there was a great deal of good work that was happening with Amanda. But one of the things that's really difficult to learn, and there was, I can only surmise, some desensitization to what was happening, was that Amanda sustained repeated injuries during the period reviewed. I'm going to come on to this later, but she was in A&E roughly once a week. So she often fell in public places, on the roads. So a road traffic accident could have been fatal, or a head injury could have been fatal, or contributed to more significant brain injury. She often lost possessions. She might have been robbed, and some of her injuries were highly suggestive of assault. Next slide, please. So during the period of the review, so that's just the 18 months before she died, she attended, it's recorded that she attended hospital on 73 occasions, so the emergency department, and she also had 3 hospital admissions. And most of those were to do with being drunk in a public place and falling and injuring herself. And at least 55 of those attendances, she was conveyed by the London Ambulance Service. Sometimes she was taken by members of the public. Sometimes she was sent in a taxi. The police were often involved in these incidents as well. So just think about it, 73 emergency department attendances in 18 months and 3 hospital admissions, and very probably other incidents that didn't reach that level of intervention. Next slide, please. So one of the things that didn't happen is that the safeguarding net didn't pull together to see the totality of that picture. So the picture was known in a fragmented way, in partial ways. Some people knew a lot more about what was happening. Other people just knew bits of it. But somehow the safeguarding processes didn't pull together to say, how do we look at this picture in its totality? And after she went missing, it suddenly became clearer the extent to which she socialized quite a lot with people living on the street. So that had been known, but it somehow hadn't raised sufficient concerns about her vulnerability. So if you think about it, she was a woman who was often intoxicated in public places and was therefore potentially easily robbed, often assaulted, in ways that really placed her at sexual danger, at danger of financial exploitation, and of course at danger of death. Now, we don't know whether she died as a result of her involvement with other people. That's not known, but she was at risk. Next slide, please. So one of the questions that I asked in the review was, at what point could the system have convened a multi-agency risk panel? Members of the system that were looking after Amanda did come together from time to time. So the hospital invoked its frequent attender protocol. She was looked after in mental health services under the care program approach, and there were CPA review meetings. But somehow in the hurly-burly of what was happening, the whole system that was involved in the circumstances of Amanda's life didn't come together. And a multi-agency risk panel might have been able to do a 360-degree view of what was happening with Amanda. And of course, absolutely crucially, discussing it more freely and fully with Amanda in the times that she was able to be more engaged. When she wasn't intoxicated, she was often assessed as having full capacity. We can think about her executive capacity, but when she wasn't drinking, she was engaged with people. And if you remember, I mentioned that she was in the pipeline for a detox placement. Now, if that could have been brought forward, expedited, she was willing, she was reducing her alcohol. We might have had a different trajectory in terms of what happened to Amanda. Next slide, please. So I've talked a bit about the stepped process, and I haven't gone into the detail, but at step C of the framework, there are opportunities then for the system to think about how do we get some expert legal advice or some expert practitioner advice to really think about what additional possibilities do we have within the law to do something different to protect Amanda. So there had been discussions about deprivation of liberty safeguards, and it was very tricky legally because she would leave her care home sober with capacity to choose to go out from the perspective of those involved with her, and yet very soon after she might well have been completely intoxicated, and that was really hard to know and to witness for those that were involved in her care. But really expediting the detox placement, as I've said, was an option that could have might have been a different intervention. And along the way, I mean, this is maybe quite marginal, but there were no evidence of any discussions with her about any assistive technology, any way that she could protect her body. She had had broken limbs in the past. There were things that she might well have been able to do just to reduce the likelihood of physical trauma as well, and including doing perhaps some different things in terms of tracking with her mobile phone. Now, all of that is quite at the edge, but nevertheless, these were things that weren't discussed. What isn't at the edge is the system coming together to say, what can we do within the law, looking at that, looking at some of those options and really getting some very expert legal advice. Next slide, please. So I'm coming to the end now. The SAR has 12 recommendations in total. There are some recommendations around training, and today is part of that. Part of Amanda's challenges were around her alcohol dependency and how the system could intervene or not. But also thinking about what happens to all of us when we are just take for granted that what we're witnessing is just normal for that person. And we don't step back to think, really? Injuries once a week that lead to an A&E consultation? Is that really not a safeguarding issue for someone as vulnerable as Amanda? Clearly it was. The SAR also asked Lewisham to be clearer about how to convene multi-agency risk panels. Lewisham had a number of different things that were close to that, but it didn't have that exactly at the time that Amanda was in these circumstances. We also identified that there was quite a lot of data that was in different places. So I can see the questions popping in. I'm trying not to get distracted by them, but we will answer some of them later, I'm sure. There was data that was being captured through the NHS system DATEX, which wasn't finding its way into the safeguarding system. And that meant that really nobody had a full picture. And there was insufficient compliance with safeguarding requirements. So there were safeguarding concerns. Some of them were getting moved on to the next stage, but they weren't being followed through. And it isn't a question so much of any particular incident, it's the whole picture that was building up and had been building up for some time. And then there were some community safety considerations. So what do we do as a system when we are working with people who are very vulnerable and they are mixing with people who are likely to be more dangerous, perhaps be harmful to them? The overlap between adult social care issues and community safety issues. So there were some recommendations around that. And then finally, I just want to mention a particular issue of sadness. The family, and they have produced a very moving comment to go with the publication of the SAR, and that's also on the website, felt that they didn't get the support from the police to investigate her missing adequately. And they themselves then moved into trying to find out what had happened to Amanda. And it was as a result of things that they were able to find out that the police were then able to resume their investigation, and sadly then found Amanda's body in a derelict, boarded up garage. So the police have been asked to work again with Amanda's family to understand what could have been done differently. So I want to just thank you for listening. I can see a lot of questions have been popping in, and we'll do our best to answer those later.
You've still got, Susan, we've still got until 14:45 in this segment, so you can answer questions now for 9 minutes.
Oh, I can answer. So I've gone. Okay, let's go to the. So can I ask, while I look, can I ask colleagues in Lewisham to talk about the multi-agency arrangements?
Martin, can you do that?
Yeah, in terms of that, the question someone's asked around, is there a formal multi-agency panel, a MARM process? The answer is no, there isn't. So as you said earlier, Susan, that was still the case back during the time period of the review. So it has been considered again as part of this review and the action plan process and the recommendations. And it's been considered not just in the context of this review, but more generally as well. And it's been brought up at another summit we've had recently around self-neglect, hoarding and housing related issues. So the answer is no, it's still under review. There's still no firm decision. But the intention, I think, at the moment is to further strengthen Section 42 procedures and the use of the multi-agency meetings through that process to achieve that result, really. But yeah, still no firm decision, but it may be in the future.
So I'm going to go to the question about Section 117. So David, you ask, is Section 117 aftercare seen merely as a passport to finance a package of care, or is it viewed as a framework to coordinate care? Has its essence been lost over time? So Amanda was, she was funded through Section 117. She was also subject to the care program approach. So her care was being coordinated, and she had CPA reviews, and her placement was based on her needs. But the review identifies that process was not looking at her needs in the round, insofar as her exposure to accident and violence was immensely high. So that wasn't getting picked up, in my view. I mean, colleagues, I'm not wanting to criticize individuals. I'm just saying what happened was that somehow the system wasn't calibrated to recognizing the violence that she was experiencing so comprehensively. So I'm just moving through the questions. Somebody's saying that the STEP process is really helpful, particularly in relation to mental capacity. I haven't said very much about this, but of course there is a bit of discussion in the SAR about Amanda's executive functioning, given that she'd had lifelong, or at least in all her adult life, use of substances and head injuries of one kind or another. There was no evidence of gross neurological compromise, but certainly in terms of her life experiences, trauma that she would have experienced, her use of substances, her injuries, her executive functioning came and went in a variety of ways. I do want to emphasize that some very good things happened with Amanda as well. So during the period of the review, she received and complied with and successfully came out the other side of hepatitis C treatment. And she was reducing her drinking. So you know, there's some evidence in her story that focus at sometimes worked for her, but other times not. So there's a question here, was it not open to Section 42? Well, Amanda was dipping in and out of the safeguarding process, or at least the agencies working with her. And my view, having pulled together having seen the chronology in its integrated form and seen the totality of the violence that she was experiencing so very, very regularly, that somehow the net didn't, the safeguarding net didn't hold her tight enough. I mean, anywhere near tight enough. So had there been a safeguarding manager to oversee the totality of her experience, the outcomes might have been different, at least to get to a point to say, well, what are our legal options here in terms of restricting her movement? Because once she was out and about in the world drinking, then she was exposed to many dangers. Kate has said something about the difficulty of expediting detox. Absolutely, and in a way, if you go back to the picture that I used of the Gordian knot, as it happens with Amanda, the placement had been identified and the funding, the potential placement, and the funding had been nailed down. That had taken quite a while to get to that point. But if we're thinking about the need of somebody in these circumstances and the resources that she was using, not inappropriately because she needed care, but if you think of the time that was taken up in treating her in hospital, then you know, a detox placement might have got her onto a different bit of the spiral in terms of the next stage of her life. So Angie says something about we need to think about prejudice and judgmental behavior towards people who use substances from practitioners and clinicians, and a lot of people have ticked that. So in a way that feeds into the normalization theme. It might be because we're biased against certain types of behaviors that we turn a blind eye. So Lynette, you say, I think that there is difficulty with services to engage with people who have alcohol dependency. I would agree with you that that's generally true. But let's just remember that there were 1,300 contacts, not all of them directly with her, to be fair. So there actually was a huge amount of engagement with Amanda. This is in some respects quite unusual. But not to an outcome that protected her. I'm just looking through to see whether there's any questions on different. I think I'm coming up to the end of the time now, Martin. So perhaps if I pause, let Patrick follow, and I'll have a look at the questions for when we get to the Q&A.